Dr. Abram is certified by the Board of Neurological Surgery and is the co-medical director of the Unity System at St. Thomas Health. And joining him is Dr. Paul Rosenblatt, who's a radiation oncologist at St. Thomas Health in Nashville.
The etiology of these discussions is sort of to create a peer-to-peer discussion opportunity. So as you know, the web platform is less than ideal. We'd love it to be in person, but you know, if people could treat it as though it's an in-person discussion, maybe keep your cameras on if you have the opportunity to do that, and we want it to be a discussion. So you know, let it be casual. Feel free to ask questions along the way, and we're really looking forward to Dr. Abram and Dr. Rosenblatt sharing their experience. So thank you again.
We're in our Dan Rudy Cancer Center. We just completed our brain tumor board, so I apologize for any of the backdrop overhead announcing system that might interrupt us, but we're in a hospital as some of you are, so you get that. As I said, Dr. Rosenblatt and I just completed our brain tumor board, and I thought that for the sake of discussion, we would present cases kind of like we do in brain tumor board and run through our thoughts and some outcomes on patients that have undergone neuroblate, laser interstitial thermal therapy, and we were asked to focus on metastatic lesions and specifically radiation necrosis. So I think I'll run through these cases, and if anybody has any questions, just jump in and let's just open it up for discussion if that works for everybody else. So our first case is a 77-year-old gentleman has a history of both periorbital basal cell carcinoma and a renal cell. Renal cell carcinoma with nephrectomy was remote in 1997. He had a recurrence of his basal cell in 2019, and upon staging was found to have 2 cerebellar lesions. So he had 2 cerebellar lesions. These are actually 2 lesions on different planes, even though they look pretty similar. And then he had 2 small spots supratentorially as well. These 4 lesions underwent radiosurgery, and then he had adjuvant chemotherapies and immunotherapies. This posterior lesion at the atrium started blooming and recurring, mass effective, developing some symptoms of weakness appropriately. So we talked about this. We needed tissue diagnosis to decide on his treatment planning. So I think that opens up one of the first salient points I'd like to raise in our institution when we talk to our patients about the need for tissue diagnosis. So a surgery for diagnostic purposes can be converted into a same sitting into a procedure of treatment, a therapeutic procedure through neuroblate or LITT. And it's with the hope that we can, through this more minimally invasive technique, obviate the need for a more aggressive, open surgical craniotomy. But that's kind of how we couch it, to be able to perform a procedure for diagnosis and then convert that immediately into a potential therapeutic. So you see here our placement of our catheter, both for biopsy and then subsequently for the neuroblate initiation. So this came back primarily, I don't have it listed here. It was 50-50 radiation necrosis and viable tumor on the frozen section. And again, the point there that I'd like to make is that when we do these neuroblate procedures, we base our degree of energy that we provide in the ablation cognizant of that frozen section. So if it's primarily radiation necrosis, we can use a lower energy ablation, and we're not so motivated to have 100% coverage as we would as if this is a viable tumor recurrence. And that becomes important when you have eloquent fiber tracts, which I'll show you here. But in this patient, it was 50-50. So we were motivated to really get as much coverage as we could, as well as a higher energy dose, which is reflected by this blue line. Now, you kind of see the leaching of contrast outside. The blue line really mimics the preoperative contrast that we get the morning of the operation. So by the time we get our imaging for the neuroblate or the conclusion scan that shows where we put our ablation, this is going to mimic conformally our preoperative instead of this leaching. So this really was an excellent coverage of the metastatic lesion, and I'd like to run that loop so you can kind of see how it goes. Keith, can you run that video? And so this is the sort of the loop that shows the time of ablation was about 21 and a half minutes. You can see the development of both the yellow and the blue lines as we progress into this tumor cognizant. The white are the eloquent fiber tracks that we've downloaded. Again, really an advantage that NeuroBlate provides so that we can conformally lay down the ablation. I always go in a deep to proximal or cortical direction, although there are others, colleagues of mine at other centers that are experienced that really don't like to insert the catheter and then ablate deep to proximal, because then theoretically you're bringing out the catheter with untreated tissue to seed your tract. But I biopsy all these, so I've already done that theoretically. So I seem to have a predilection for logistic reasons and expediency to go deep to proximal, but that's a side issue. So you can kind of see how this goes. Again, it took almost 22 minutes of ablation. Again, sorry for the overhead. So here you see a follow-up, 2-month follow-up, and on T2 you can see this rim, eggshell thin rim is kind of the typical look of an ablated lesion. Again, here it is with T1 contrast. You can see how succinct it is, less flare, less edema, less problem, and he's done very well. So this is, again, he had a biopsy and then treatment in the same sitting in a minimally invasive technique that he went home the following morning after this procedure, and he's remained stable.
And then if I could interject one thing, part of the reason for a non-surgical preference for NeuroBlate in this individual, he was a brittle insulin-dependent diabetic, so he did not tolerate steroids well at all. And so that prompted us to want to ablate the source of the swelling as rapidly as possible, and he also wouldn't have tolerated VEGF well based on his overall physical condition. So the NeuroBlate helped us avoid his being on steroids for a long time.
That's true. The ability to get patients off steroids relatively quickly, I've learned in doing this, I initially got them off in a matter of days. Now I get them off the steroids, and it's usually a slower wean of maybe over 2 weeks or so. But it's still, of course, the hospital paging system is hyperactive today, more than I've ever heard. But anyway, we are able to get these patients weaned off the steroids in short order, which has been advantageous. So the next patient is a 53-year-old metastatic breast, ER/PR positive, HER2 positive. She'd had radiosurgery to a left parietal lobe lesion, and then by October, about 8-9 months later, surveillance MRI scan showed increasing edema to parietal lobe. The patient was placed on Trental and vitamin E, and the area of concern was progressing. So again, we wanted to know radiation necrosis versus metastatic recurrence despite the radiosurgery. So talking it over, this is a relative cortical lesion, albeit in a potentially eloquent location. A biopsy could be performed, but in our hands, we discussed this with the patient and her family that we could do the biopsy, which we need for restaging, and convert that into a potential therapeutic procedure with the hope that we can obviate the need for a craniotomy, which they were excited about, and we proceeded with. This came back 10% radiation necrosis, and the majority of which was viable tumor. So again, the energy that we wanted to provide, despite these eloquent fiber tracts, which I think was mostly vision that we're highlighting on the screen, we delivered the blue line, or the higher energy line, which ends up being 43 degrees over 10 minutes, or a second for 60 degrees, which is instant cell death. So that's the kind of energy we want to apply to something that's recurrent viable metastatic cancers. And in this patient, again, so I will, for viable tumor wanting to deliver the type of energy we want, I will sometimes leach the lesion for the sake of maximal coverage into the fiber tract. But that's a sort of an intraoperative decision based on the biopsy findings and kind of how much I want to get into. But you can see on the lower left, I clipped the back portion of that. And fortunately, when she woke up, she was, and the subsequent follow-up, she did not have any visual deficits or any visual untoward effect from that. And she was also discharged the following morning. And her follow-up, can you stop the loop then? And the treatment time for that one, I think, was about 12 minutes. And then we see here, this is, I think, a good point to make. This is her February scan immediately after the ablation. So you see T1 with contrast, and you see how it's smaller. However, you see this raggedy kind of border to the enhancement, nodularity and kind of raggedy, despite being overall volumetrically smaller. You see it as well on the T2, comparatively significantly smaller. The actual amount of T2 and flare on this, although on this image looks more, it's about stable, but the lesion is remarkably small. And what we're seeing is, when we do these ablations, we find that the lesions kind of over time contract and cave in on themselves, and the border will look like this, raggedy through that time frame of initial follow-up. And over time, it kind of continues to fade. But we're always concerned about this actually showing progression, or is it just this treatment follow-up? And that's what this seems like, but we'll be continuing to follow it very carefully. In fact, we've got a PET scan pending to try to help us out with if this is still active or not. I believe it's going to be sort of the treatment effect that we've experienced.
So the other thing in this lady, after her neuroblast, because she had so much tumor, we were able to follow up with some more radiosurgery, and rather than post-craniotomy difficulty targeting the metastatic area, she's got a tumor target even a neurosurgeon could draw out, and so she's actually done quite well, and I think it is necrosis. I agree with Dr. Abram at this point. The other point on her, she's one of the HER2 positive breast cancers, and we're seeing increased incidence of necrosis with the HER2 people as opposed to, say, lung cancers or colon cancers.
Again, if there's any questions as we're plowing through, please feel free to interrupt.
I have a question, actually.
Okay.
Have you ever seen a situation, since we're speaking about this, where you're treating something that you're concerned for necrosis, and then you use LITT, and then following LITT, you get an even bigger response of necrosis?
we've not seen an exacerbation of a necrosis. In fact, the LITT seems to be very powerful in our experience thus far in managing radiation necrosis. You know, it's a vascular phenomenon, and the LITT seems, as I said earlier, we don't seem to have to provide as high an energy, which speaks to your point. Are we seeing that the lesioning of these tissues, is that causing a malignant edema or reactive response? And we've not seen it. We deliver a lower dose energy, and we're not really over concerned about complete coverage. So when we get a 60%, 70% coverage of these things, cognizant of eloquent fiber tracts, we've gone on to very good results, particularly with radiation necrosis. So a long way to say no, we haven't seen that.
Yeah, I think the radiation necrosis pathophysiologically is a little different than standard necrosis. So after the radiation, you've got this perilesional hypoxic area of astrocytes, microglia, that's leaky, and you have this cytokine cascade coming out with hypoxia-induced factors and interleukins. So I think it gets into a cycle of ischemia, more necrosis, and more inflammation, whereas after the LITT, I think we've removed that irritative focus, and we've not seen sort of a second blooming, if you will.
Yeah, no, I get all that. Yeah, I did a case recently here for a person who had like a gliosarcoma that recurred after, I don't know, it was many years. It was in 2017. So I did this LITT procedure for this small lesion. I'll tell you, maybe 2 to 3 months later, it blew up to something that was about 4 to 5 times the size. And I went ahead and had to do an open resection, and the majority of that was necrosis and not tumor. And so I was very, again, that's a freak thing. I've never seen that before in my experience with LITT, but I just wanted to bring it up because I'd never seen anything like it.
What's the
Can I comment something?
were they on for the gliosarcomas? Because we've noticed a real potentiating effect of certain chemos over others.
Oh yeah, the person was. Oh, sorry. I was going to say one last thing about it. The person was only on taking PPF, right? The the little cap that they put on their head. Sorry for the. I'm forgetting the name right now, but
correct, right? The option.
But I will say that their last radiation treatment was about 1.5 years before that, actually. And then they were not on any chemotherapies. There was nothing else. It was very weird.
That is peculiar.
That's weird. I agree. But it sounds like that kind of blew up into a bad animal.
I agree. But it's okay. We can continue. It was just kind of a weird thing. I just wanted to ask if anybody saw something.
Sure.
Let me mention something. I think we were the one who reported the first case of treatment with LITT for radiation necrosis at Cleveland Clinic. And what we had seen is that the first 3 months, you can have some edema, perilesional edema after LITT in the area that you treated. I don't remember a case all the way to 6 months, but sometimes you can develop some edema around the area that you treated after radiation necrosis or after tumor ablation, and then that edema starts to disappear after 3 months. So you still need to treat the patient with a steroid for a certain period of time, or Avastin if it's necessary. And then the tumor will start to, the edema will start to disappear and the tumor start to disappear. That was one of our experience.
And we also, you really rely on Trental and vitamin E.
Mm-hmm.
Yeah, we didn't get that information that time. So we're talking about like 8 years ago, more or less, or more than 8 years ago.
Right. The next case is a patient I wanted to highlight because of its location, really, more than anything, just what we're capable of. And from a neurosurgical perspective, we always think of posterior fossa lesions as difficult to access. But in any regard, this is a patient who's had a serous carcinoma, had a resection of this after she presented with posterior fossa. And here's the conclusion scan. This little dot over here is actually blood. It's not enhancing mass. So we thought we'd had a gross total resection. And then she came back about a year later with, again, posterior fossa symptoms that she had resolved, and this large enhancing sort of transtentorial mass that we needed to relieve because of mass effect. Now she's in her mid-70s and otherwise not real healthy. We were concerned about a repeat craniotomy to relieve this mass effect. So we offered again, we wanted to restage, biopsy it, and go ahead and offer the therapeutic procedure of LITT. Now I was planning on doing a 2-trajectory pass. So one into this major part in her cerebellum, but another above the tentorium. But by the time she'd been placed on vitamin E and Trentel, so by that time you can see on this coronal, the occipital stuff had kind of withered away, so I didn't have to do a second trajectory. We went ahead and did the first one trajectory into the posterior fossa. And again, there's some other technical considerations in doing a posterior fossa. Instead of a little stab incision to place the neuroblate bolt, you have to make a little bit more of an incision so that you can accommodate the subcutaneous tissues and muscle to make sure the bolt is accessible to your catheter. So it requires a little bit more of an incision, but placement of the bolt. You also have to, we get a preoperative CAT scan and fuse it so that we make sure this lady had a suboccipital craniectomy, so we had to find a bone that would accommodate the trajectory or a corridor that we chose, but that there had to be bone to anchor the bolt to. So again, this was all radiation necrosis. Keith, you want to run that loop? And so a yellow energy line, a lower energy line. I'm not overly anxious about getting 100% coverage, but what comes easily, obviously there's no fiber tracking for the posterior fossa, but you can see our yellow line as it progresses through the treatment. And this took, I think, on the order of 12 minutes of total ablation time. Now, when I say 12 minutes of ablation time, I mean, obviously there's the whole logistic of the entire process. I think we've got it down to where my involvement by the time I'm starting the case to when I leave the brain suite, it's usually about an hour and 45 minutes and change. So we've kind of sped up that process or made it as efficient as possible, which as a private practice neurosurgeon was very important that, that I try to remain efficient and productive. And we've been able to manage that with the logistics of this. So again, you can see the process. This lady's symptoms really improved remarkably, and she stayed, I think, 2 days post-op instead of our typical 1 day for other reasons, but not related to this. Her posterior fossa symptoms really remarkably improved pretty quickly.
So that will be my question. So what is exactly the flow that you have? So you bring the patient to the OR, do the navigation system, put the catheter, and then you transfer the patient to the MRI suite, correct?
No. So what we do is we have an intraoperative MRI brain suite. So what we do, our throughput is the patient gets a study the morning of the procedure, an MRI scan, CAT scan, whatever they need for our planning. I do the planning, and then the patient comes into the OR, is asleep. We put them in the surgical position, but we attach fiducial markings to the scalp. We bring in the MRI scan, the IMRIS MRI into the room, get our scan with the fiducials, and it takes maybe on the order of under 10 minutes. Then we register using those fiducials so that we really improved our accuracy of the catheter placements. That's key, because when we found we were millimeters off on our placement because of registration, it kind of made us have to go to a different catheter, like a side fire, where I could have more direction. But the more accurate we are, the more succinct our treatments become. So using this fiducial technique, I think we've gotten our accuracy down to a millimeter, about a millimeter. So we're able to, a lot of times, use the diffuse tip and don't have to use the side fire. In any regard, then we do the procedure. So placement of the bolt through a stab incision, and that takes on the order of another 10 minutes, 12 minutes. Then we go to our brain suite with the workstation, which is in the OR and next to the OR, and we perform the ablation, get our appropriate scans, perform the ablation, fuse in our fiber tracks to the treatment scans as you've seen. And again, my involvement is about an hour and 45 minutes typically.
So what would be your recommendation for people who doesn't have intraoperative MRI?
Yeah, so then I would, that's a problem. I might still put the fiducials on, then you have to take the patient, I might skip that step. I might just try to be as accurate as you can with your registration, but for treatment, you have to take the patient to the MRI suite. I think you would skip the fiducial marking registration aspect of it. That scan, because then you'd have to take the patient back and forth twice.
Rely more on height than thin slice CT.
Yeah. So again, you can fuse thin slice CTs from preoperative to help your accuracy in registration. But I wouldn't go back and forth. Once you go to the MRI scan, I wouldn't go back and forth. So that's obviously going to increase your time commitment.
For about 2 to 3 millimeters on CT.
Okay, here's a good case. I think I like this case because anyway, this is a 66-year-old patient, metastatic lung, that was treated in an outside institution. There were 4 lesions. I'm showing you 2 of these, but I'll show you later the other 2. But these 4 lesions, there was this left frontal, this insular, there's a occipital lesion, and then there's a perifalcine parietal kind of lesion, all of which were treated with radiosurgery in 2018. But by February to March, we see the expansion, in particular, of this insular lesion on the left. The frontal lesion is slightly bigger as well, but not to the degree on T2 and flare that this lesion was erupting, and the patient was becoming really aphasic. So an insular lesion left, we decided to offer the patient a neuroablate procedure, biopsy and neuroablate. This turned out to be 100% radiation necrosis. So here's our treatment plan. And again, you can see it's blowing up even more by the time we got her to treatment, and the surrounding edema pattern, even on the T1 without or with. Here is our planning with the fiber tracking and the arcuate in particular, and corticospinal tract. So we go ahead and do that procedure. 100% radiation necrosis, so cognizant of these fiber tracts, I was able to deliver the lower dose, not really anxious to leach into any of these fiber tracts that we thought were eloquent, particularly the internal capsule and arcuate. So a total time of 20 minutes. I went slow, delivering a lower dose energy, going slow, again, really being careful of the fiber tracts for her, and procedure that ablation of 20 minutes or so. And this patient went home the following morning, aphasia, not with a dramatic improvement in her aphasia on short order. So she went on, okay, Keith, you can cut that one off. She went on for follow-up, and now we start to see an increase in the left frontal lesion pretty dramatically. And again, a lot of surrounding edema. She's getting headaches. This, you can see the follow-up of this insular lesion contracting nicely at this point. But this is mostly headache. She is having recurrence of aphasia as well. You know, this is getting close to Broca's or that end of the arcuate. And so we had such a great result, and she had a good experience with the first one. We went in and offered it again. So this is her second sitting. You can see now by the time of treatment how much bigger that left frontal one is becoming. The temporal insular one is really fading. So again, we see our eloquent fiber tracts, the arcuate in particular, and she goes on to treatment of that one. Again, 100% radiation necrosis, matching our experience with the other insular lesion. We delivered that. Keith, run that one. So again, a yellow line, lower energies, relatively slow, really cognizant of that arcuate. So this one took about 10 minutes of ablation time. So this is sort of a heads up and a loop of what we're seeing as we are delivering the ablation. So she goes home, again, same experience as the last time, goes home the following day, no headache, and her aphasia is remarkably improved. Okay, Keith, that's good. So then we continue to follow up with her, serial MRI scans, and now another lesion is blooming. One of the 4 lesions that was treated, this posterior frontal sort of paramidline lesion, is blooming. You can see the frontal lesion at this time over here on the far left is basically gone. The insular lesion is basically gone. Here's that corpus callosal or occipital lesion here that's always remained quiescent, stable, never changes. But this one is blooming, and her aphasia was relatively stable, but we've done in short order, you know, months before, did 2 other lesions, 100% radiation necrosis. We talked about this again. The family is really gung-ho. If this is what we got to do to keep control, an overnight stay, we go ahead and get this planned. You can see on this image, I wanted to highlight how we do our planning, and this shows, so I pick my trajectory, and then I use usually about a 25 millimeter cylinder on either side to kind of show what I expect my coverage to be, so that I can plan out whether this is, I'm going to cover it well enough with one trajectory versus 2, or how to optimize the actual corridor for both biopsy and treatment. And again, cognizant of her corticospinal tract and that arcuate. So we go ahead with this treatment planning, and lo and behold, it is 100% recurrence of her poorly differentiated non-small cell carcinoma. So we got a little bit of a curveball on this one. So despite the other 2 being radiation necrosis, we could handle that. So intraoperatively, we change our plan from the low energy into a more potent energy with the blue line. And I did leach it into sort of the tip of the arcuate. If you want to run that loop, Keith, again, thinking that this is 100% radiation, 100% recurrent tumor, we went ahead with the higher energy, and you'll see my kind of yellow getting close to it, but the blue will clip on the far left. You'll see it'll start to clip some of that arcuate, saying that, you know, it's a little bit, and for the sake of really good coverage, we wanted to provide that kind of an energy and coverage. So she wakes up this time and is really aphasic. So what I thought was just a little bit of a clip into that turned out to be pretty profound. And I'm learning that that despite it looking like a minimal, it can have profound effect, but it's something that patients typically improve from in relative short order. As she did, it required a stay of a few days, not just overnight. We kept her for 3 days, higher dose steroid, and let her improve a bit before she went home with home health and speech therapy, but it's getting better. But I thought this was an interesting case that these lesions were treated differently, but we've been keeping control of them thus far through this neuroblade. Does that generate any comment or?
No, again, right now our diagnostic tests preoperatively aren't that helpful on a lot of these cases, despite some of the newer advances in the academic setting. Again, the ability to get that biopsy beforehand helped us.
So what do you use for a diagnosis for radiation necrosis? PET scan or blood volume?
I'm sorry, how do we do our diagnosis is presumptive, but then we will get a biopsy. That's what we're saying.
Before biopsy. When you are in tumor board and you have a suspicious of radiation necrosis, do you have a PET scan before that said that, okay, this is possible radiation necrosis or this is recurrence?
Sometimes we'll get a PET scan, but again, as you know, it's so vague that oftentimes we'll say, because we have the system, we'll say, well, let's just find out and be definitive about it, and that's when we will proceed with a biopsy. But that's kind of the impetus behind why we're aggressive, if you will, with the neuroblade, because it allows us to get a biopsy we're not guessing anymore based on the MR characteristics of the PET scan vagaries, and we're able to get a definitive answer, but then convert that immediately into a potential therapy.
Our PET scan experience has been very equivocal. We've tried some of the newer perfusion techniques. Again, the problem at a private hospital, the length of time for that delayed perfusion scan has met some resistance. I think that could be very promising.
Okay. So the other thing that I see that you have yellow and blue line. Are we still using the white line in the system?
Yeah, we can see the white line, obviously. The white line is the energy level of a nuclear blast. And so we just follow, during the treatments, I always follow the yellow and the blue. I will go back to a white oftentimes, but I'm not really utilizing it just to make sure I'm being safe, but I'm not really utilizing that because by using the blue line, I'm making sure that I'm not at a white line. Again, a white line is for sure cell death immediately at less than a second. So if I followed the white line, by the time I saw that it was going where I don't want it to go, it's too late. Versus the blue and the yellow give me the luxury of safety.
Got it. Thank you.
But if anybody has any questions or any other things we can answer, it's been a huge adjunct for us as another option. Again, it's really resonates with our patients when we say we have a minimally invasive technique. Potentially, when we get our biopsy, we can convert that into not only a diagnostic but a therapeutic procedure, and it doesn't take off the table a craniotomy. It just hopefully obviates the indication or need for the craniotomy. We've done a lot of gliomas that are deep-seated and otherwise patients that are medically frail, and we've had good results with that. I don't think the results thus far have not been better than a resection, a safe maximal resection, but the concept of safe maximal ablation is, to me, thus far, anecdotally, equivalent to what we would expect with a safe maximal resection. And then it's better in that it's a minimally invasive technique, and they potentially get to go home the following day on a lot less steroid dependent.
The other way I think it's better, it's lower cost for one thing. Number two, in some of these patients that have not had total systemic control and may have a year and a half to live, I think not having to recover from a craniotomy is a good thing. It's not going to be reported in a quality of life study because we don't frequently look at that in palliation of brain mets, but I think it's a valid consideration that whereas the cranie takes them frequently weeks to recover from. It does allow me not to worry so much in terms of pushing the dose on some of our patients, because basically we want a necrosis tumor. This way I've got a safety mechanism.
So how you're coding this? As a craniotomy, as a special different code? So how do you do this?
So right now there's not a specific code for this. We code for a biopsy, obviously a stereotactic biopsy, and then we code for the bolt placement, neuroblade, and there's a procedure code that is not experimental, but not yet defined. It's kind of how they describe it. But I understand maybe Jim and you guys can talk about what you've been doing to get a specific code for this.
Yeah.
We've had a relatively mixed bag of getting approvals, although it seems when I talk to other centers, we have a lot less trouble getting these things approved. But our administration's really active, and when we're having trouble, they'll call up the insurer and discuss with them and explain to them what we're doing and really work hard. But Monteris has outsourced a consultant group that can help all that logistic on getting it approved as well. I don't know,
that's
Jim,
exactly what I was going to. That's exactly what I was going to add, Dr. Abram. Is we do have a reimbursement group that can help you with that. The DRG code for the hospital's procedure is the same as the craniotomy. The ICD-10 actually maps into the craniotomy code. But to Dr. Abram's point, the CPT code for your the physician's time is something we've been working on with the societies and the AMA going forward to end up with something, get something established there, and we're optimistic that we'll be working forward on that. But we do have a reimbursement team that can help you with any coverage issues that you run into relative to hospital or payer coverages. There's positive coverages coming out periodically, but we recognize that can be a battle sometimes. Then thanks very much, Dr. Abram Rosenblatt. I think this was a great little talk. I think it helped bring out some real important things that I think many people learn along their journey. So thank you very much.
Well, thank you, and have a good day, everybody.
Stay safe.